Hello and welcome to the course. I'm your host today, Lee, and I'm speaking with Professor of Medicine and Epidemiology, Dr. John Schneider, who is a network epidemiologist and infectious disease specialist from the Departments of Medicine and Public Health Sciences at the University of Chicago. He is also director of the University of Chicago Center for HIV Elimination. His NIH and CDC-funded research focuses on social network interventions that can lead to disease elimination in vulnerable populations. Clinically, he specializes in HIV prevention and has a specific interest in the provision of high-quality care to young Black men who have sex with men and transgender women. Professor Schneider is here to talk to us about his career path and how he became a University of Chicago professor. John, can you start us off by telling me a little bit about your career path, beginning from your undergraduate years to your role today at the University of Chicago?
Okay, I hope you have enough time. So I did an undergraduate double major at the University of California at Berkeley. I did integrative biology and interdisciplinary studies, which included anthropology, demography, and public health. So I was, interested in pre-med and interested in science, but then also was really interested in how those things are applied in the real world. So that hence the public health and anthropology components. Took me about 4.5 years to finish that. I did a study abroad, which also kind of extended things. And so then I had a half year off before I started medical school. In the half year off, I was a birding guide. I'm into birds. And so I gave tours to people. So I went to medical school at Tufts in Boston, and I did a MD, and I also got my master's in public health during that time as well. I'm from the Chicagoland area. So I was on the West Coast and the East Coast. And then I came back to Chicago at the University of Chicago. I did my internship and residency in internal medicine at the University of Chicago, which was great training. Then I did a fellowship in infectious diseases at the University of Chicago and University of Illinois. It was a combined program. And then I did a research fellowship, which was out of Brown and Tufts, a research fellowship doing HIV prevention. And during that time, I lived in India where I was doing global health. And so I was there for 2 years. And then I came back and I became faculty in 2008 and just kind of worked myself through the research and service and clinical programs. And now I'm a professor at the University of Chicago. So I've been a faculty member at the University of Chicago since 2008. So that's about 15 years or so.
And within your role at the university, what are your particular research interests today?
Yeah, so I'm really a public health sort of person. So I'm infectious diseases. I do a lot of work with HIV and sexually transmitted infections. A lot of the communities I work with also experience criminal legal involvement. So I do work in criminal justice and work with people coming in and out of jail, and then substance use treatment and prevention. So those are the kind of the topic areas, but the research itself is basically doing interventions. So trying to prevent, people getting HIV or STIs through large sort of network intervention programs. So things like, training community members to kind of disseminate information to their peers, both in the US and internationally. A lot of my focus has been on the south side of Chicago and south of the university, where it's a predominantly Black African-American community that I've been working with for a very long time and am pretty well known by the community for clinical and research work.
And what is it about public health specifically that has drawn your interest?
Yeah, so, I in medical school, we're kind of taught to look at the individual, and everything is about kind of the individual and kind of their physiology and pathology and things like that. But I early on recognized that, people's health is really driven by the circumstances they find themselves. So what drew me to public health is that in medical school, again, it was all about the individual, the physiology, the pathology. And I quickly recognized that people's health is driven by the environment, the social and structural factors, social determinants of health. So things like, do people have housing? Are they experiencing racism or homophobia? Do they have the right employment? Do they have enough food to eat? So those sorts of factors drive health. It's not, sure, there's other things that genetics and things like that people are experiencing, but most of it is the environment and the social determinants of health. So that drove me to public health, because public health looks at systems and larger forces other than, genetics or taking a certain medication or something like that.
And so tell me about what you thought you were going to be when you were a kid.
So I remember in high school, I read The Hot Zone, which was like about Ebola and kind of all these, really virulent pathogenic viruses that were killing people mostly in Africa. And I was kind of drawn to that and thinking, how can I help that issue? But what's interesting is my dad had me take this, like, it was like this test where you answer like 150 questions, and you answer things like, do you like working with people? Do you like science? All these different things. And the end result of that was, it said I was going to be a mortician and work in a funeral home. And that to me was a little, like, I didn't quite understand that. I was like, oh my gosh, I don't want to do that at all. And, why did it say that I want, and now I know why I had a predisposition to be a mortician. It's really because there's a little bit of science, right? You're preparing the bodies, but also there's this human side of working with families who are in bereavement. And so I think that's why that was the job for me. But clearly I didn't follow that path. My father recommended also that I become my own boss. Like when kind of be independent and not have to, really report to too many people. And so it just seemed at that time medicine was the path for me. Obviously, medicine has changed over the last 20 years, but at that time, that was kind of the path. So I knew I was going to do something kind of science related, maybe something health related in high school, but I didn't know quite yet what. I did pre-med. I had a couple rotations in college with physicians and recognized that that's what I wanted to do.
Who was supporting you through the years that you spent training for the role that you have today?
Yeah, I mean, it was a bit of a slog, a lot of the, didactic coursework. But I think what really kept me going during medical school is I did get a master's in public health, which I know, we have now at the University of Chicago over the last few years. I'm part of the master's in public health program in public health sciences at U of C. Those courses were super interesting. Like, for example, we had Paul Farmer, who I don't know if but maybe some of the students might know. It's just an amazing kind of public health anthropologist, activist. And he came in, he taught a portion of one of our courses. And so it was those sorts of experiences during medical school that I think really kept me going, particularly in the first 2 years. The second 2 years was, in the hospital and seeing patients. And that was super interesting, even though it was really hard. At least, that's where I really excelled. And, just kind of being able to understand problems, talk to people. Those were some of my strengths. So it was really some of the non, traditional medical courses that really kept me going. Also thinking that I was going to do global health. That's when I was, interested in global health. Those were sort of the kind of scholastic things that were keeping me going. Clearly I had support from friends and family and a partner and things like that as well. But yeah, I would say those were the things.
And why did you decide to do the role that you have now? Why did you decide to become a professor, to do research, to work with vulnerable communities when, there are a lot of things you could do with a medical degree?
As part of that, it comes back to the MPH again, I think. As part of the MPH program, we're supposed to do a capstone project. And I found another physician scientist, Ira Wilson, who was my first mentor. He's now at Brown. And he was doing research on the physician-patient relationship and how that can help people take their medicines. And it sounds pretty like, we don't need to do research to figure that out. But in fact, there was a lot of different types of communication, different relationships between, like trust and and other, self-efficacy sorts of things we were looking at. And through that project, I collected the data, I did my own analysis, and through the skills I had learned in the MPH, and then I published a paper. And that whole process was really exciting. And I felt like I was making a contribution. I was able to share my work nationally and kind of, talk to other people about it. And it was great to kind of look at what people had done before and kind of learn, build on what others have done. So that experience, I think, again, being a curious type of person, that felt good to me. And what the other part that I liked was, for kind of a more academic position rather than, a clinician who's working in the clinic or the hospital all day, is the diversity of things that I was doing. So I would teach some, I teach the infectious disease epi course at U of C. I taught one of the big problems courses. And then I could go straight from teaching to, a meeting with, a community-based organization that's on the front lines, like trying to prevent violence on the south side of Chicago. And then I could come back to my office and I could, have a meeting with, some of my staff and research team members and talk about recruitment for a project. So it was the diversity in my day and the ability to make my schedule that was really satisfying and gratifying. And I think, lived up to the, be your own boss sort of recommendation that I've been having since I was young. So yeah, I mean, but then again, it also helps that I was very successful at getting extramural funding. I have a lot of funding from the NIH and the CDC and other places, and so the ability to get that funding also gave me kind of freedom and flexibility and increased the diversity of things I could do.
I also see that you have a specialization in HIV prevention. Is that correct?
Yeah. So that was my research fellowship 2 years before I became faculty.
So, what is it about HIV specifically? And also, what is it about the communities or the diseases that are running through the communities that you work with, some of those vulnerable populations you mentioned earlier, that is fascinating or interesting to you or holds your attention?
Yeah. So I came to HIV not how the first physicians came to HIV. They were virologists or people who were kind of clinicians. But I came to HIV because I recognized that, it's really a socially determined disease. And, to your point about vulnerable populations, like, everything that we've been dealing with right now. So, the same people who I was caring for HIV or trying to prevent HIV, who are, the people I work with are predominantly Black, sexual, and gender minorities. When COVID hit, boom, they were, deeply impacted more than other communities. Then monkeypox hit. They were, I wear another hat as a medical director at Howard Brown Health, which is the largest LGBTQ clinic in the Midwest. And we had 80% of the monkeypox cases in the state of Illinois. So, whether it's criminal justice involvement, whether it's, some of these infectious diseases, they're always going to get to people who are the most vulnerable based on their social circumstances. And so HIV, there's nothing special about HIV. I don't, particularly, think the virus is that interesting, but it's really how the infection is obtained and then how people live with HIV and some of the other social and structural factors that drive whether they survive. So early on in my undergraduate, I did some anthropology work, and there was a medical anthropologist, Lawrence Cohen, who, really had some really interesting ideas around sexuality, gender, colonialism. Actually, that was the name of the class. It was sex, gender, and colonialism. And, those were some of the drivers of HIV. And that's where I first read some of Paul Farmer's work. And then I got more of Paul Farmer in med school. And then, I met him.
What do you think were the biggest challenges that you faced as you navigated this career path?
So I think the first couple years of faculty, while I was trying to get established, like there was a period of time, I lived in India, in southern India during my research fellowship, and I ran a large CDC grant there that was trying to expand HIV prevention services. And I was trying to get established and get this what's called a career development award from the NIH to support my effort to be able to live in India and do the work there. And they just weren't accepting the grant. They didn't get funded, it didn't get funded. And so I was at this point where I was like, is academia gonna work for me if I can't get funding? And I was actually starting to look outside of academia. But I also then turned back to not just focusing on India, but I was also at the same time, I was kind of like, why am I also focusing on India when there's this huge epidemic in our backyard that the University of Chicago, really hasn't been kind of a major player in? And so I started doing a lot of stuff in the community at that time as well, and started to build. And then things started really coming through for me, and I started to get support and funding. And I did my first pilot project on the south side of Chicago. And so I think the challenge, initially was just kind of getting started. But the other thing, because the University of Chicago it's a smaller school than some of the big schools that we think about, particularly for HIV. But what it did have that I think I really benefited from were these deep, like, there's not someone who does everything at University of Chicago, but the people who do what they do, it was very deep and very, like, just amazing people. So for example, I was interested in sexual network analysis, right? And the grandfather of sex network analysis was a sociologist, Ed Lauman, who's still around. He's not at the university, and he's retired. But I would walk down the street and go and sit with him, and just in his armchair, and we would just talk about sex networks, about research questions, things like that. And so while it was hard to find Ed and initially, when I found him, it was great. And we did a lot of collaborative work together because he wasn't a physician. So we had a really nice interdisciplinary collaboration. And now I'm one of kind of the main physicians in the country who does network analysis. And it was really through that sort of experience. So I guess, to answer your question, some of those struggles in the beginning, I think, are important because, number one, it taught me to find the right people. And then number two, it taught me, if you keep getting rejected with a grant, just keep pushing, like, don't give up. And that's what I did. And then things really, the floodgates opened, and, I became very well funded.
What are your favorite parts of the job that you do? Like, what's most fun for you?
I have a half day of clinic a week now. I have my clinic off campus in Hyde Park. I started the Howard Brown Health 55th Street Clinic, and I have my clinic there. I'm no longer medical director because it just got too busy, but I have an evening clinic, and I feel very privileged to be able to take care of the patients I take care of. So, I'll take care of, so they're mostly young Black gay men, bisexual men, same gender loving men, Black trans feminine and trans masculine people. So I take care of their HIV care. I do a PrEP, which is a prevention pill to prevent HIV, also an injection. I do gender affirming hormone therapy. I also have people who have substance use disorder with, heroin or other substances. So I do substance use treatment. So I just have a really unique and special clinic that, did not exist and has never existed on the South Side, that kind of mix of patients and populations. And my favorite part is when someone comes in and says, my friend recommended you as a physician, and I feel like, okay, I'm having some impact. If my research doesn't answer the question and doesn't have an impact, at least I'm having these little kind of daily, weekly impacts on patients and their health. So that's really, and they're all young people too. So that's also really special and fun. So I think that's probably my favorite part. I do like, it sounds weird, but I do also like writing grants because it's an opportunity to be creative and kind of think through the question in real detail and spend, it's almost like you're, some sort of, living in a monastery, like you kind of wall yourself off, you kind of look through all these documents and papers and craft something that can be impactful. And so that's actually more fun for me than actually getting the grant. When I get the grant, then it's like, oh great, now I've got to do this. But the creative part is also really fun for me.
And then what advice would you have to people who are interested in public health and interested in perhaps pursuing it as an academic?
Yeah. So I advise a lot of people on that, whether they're undergrads, master's students, PhDs, MDs. And really, I guess one thing, a lot of people come to me about global health, and I'll say, you know, what you really need to get is the skills so that if you go overseas, you can actually do something other than, sort of being a public health tourist or a medical tourist. So I recommend really getting good skills in epidemiology, biostatistics, some health services research, perhaps. And so that, when you're ready to kind of create your own program or idea, you know, you can be attractive to someone like me who will then invite you to join the team. So I really think it's kind of getting those good skills, and sure, go study abroad, do a project overseas, but really focus on getting some of those skills. So I think, the skills I got during my MPH that let me do a project and get it published, like that really was the foundation for kind of the rest of the things that I built on top of that, the different types of analyses, the different types of questions I was asking. So, and, I think college, we're lucky compared to some of the European systems where they have to, decide they're going to be a doctor at the age of 18. I was lucky. I was able to explore a bit in college. So I think there's also that opportunity to explore some. If you don't want to do pre-med, that's great. Don't do it. But if you decide in your junior or senior year you want to do it, there's always post-bac programs. There's always ways to get the coursework done so that you can, go that path. I think also making sure you're not just in an ivory tower kind of reading articles and coming up with ideas, but all of my ideas I get from my clinic, or I get from going to community events, or, we have big outreach events in the park for, during Pride Month and things like that. So that's where my ideas come from. It doesn't come from reading a book, although that helps. So I'd say, get involved in local community efforts and projects and, civic stuff, politics, all of that.
And then finally, John, what do you find most fulfilling or gratifying about the work that you do?
I think, so we've created so I have an off-campus research and service space that's on the corner of 55th and Lake Park, and it's also in the same building that the Howard Brown Health Clinic is. And I think we've created a nice environment there, a safe space for people to get, healthcare services and participate in research or service programs that we offer. We have a drop-in where young people can come that don't have a place to stay and, can hang out and socialize and eat food and, watch a movie or play games. So that didn't exist before. And so we created that. So that I'm proud of that. And that makes me feel like the work I've been doing has really led to something, because we have the infrastructure now to have these programs. And then, like I mentioned before, I think the other thing I feel like I can have a, person to, one individual at a time impact. I'm a public health person, but there's still that individual kind of effect that I can have. And, when people are coming to me in clinic, the HIV part is the easiest part. The stuff that we're talking about and dealing with are, where are you sleeping tonight? Tell me more about your drinking. Like, are there ways that we can slow that down? Okay, I hear, you're using cannabis to help with your pain. Can we make sure that it doesn't turn into something, more habit forming, so kind of the non-HIV stuff. So if you read my notes, it's really talking about, their jobs and their pets and their partners and housing and things like that, which are really the drivers of what make people survive in this country.
Thank you, Professor John Schneider, for your time today. And course takers, if you enjoyed listening to today's interview, please check out the other ones. Leave us a comment, subscribe, follow, and share this episode with your friends and family. You can find out more about the University of Chicago through uchicago.edu or the university's campus in Hong Kong through uchicago.hk. Stay tuned for more, and thanks for listening.